The first sets of topics are common between both the CHW binder and the care manager binder, but then there are things that are specific to the roles that you play at your respective sites. So I just wanted to give you the heads up about that. The second is that I think many of you who were here earlier heard me talk about the pretest, which is at the back of the binder on the right-hand side. So please complete that. If you could do this sometime, either during your break or during lunch, and then hand it back to me, that would be great. And then finally, this has more to do with our colleagues at Total Healthcare. One of the things that we need from you all is to please complete this form for the JET ID. So if you could please complete all the information on this form and either give it to me or to Jennifer, that would be great. So enjoy your break, and I'll see you at 11.
I'm Carmen Alvarez. I'm faculty over in the School of Nursing, somewhat across the street. Also a family nurse practitioner, and have been practicing in community health centers for the past, I guess, almost 9 years. And really passionate about our role as healthcare workers in promoting self-management and patient activation in our clientele. So the conversation this morning is intended to be just that, a conversation. We won't, hopefully, will not be lecturing. You will be talking, telling us what you already do, a lot of what you already know. And we'll be talking about health promotion using a few theoretical frameworks to somewhat highlight the strengths in our practices and to highlight how, well, I guess the importance of working together as a team for meeting our patients' needs, which are quite heavily, as we all already know. So I will go ahead and let Chidinma introduce herself and get started.
Hi everyone. So some of you already know me via email, and then we met this morning, but just to introduce myself again, I'm Chidinma Ibe. I'm a member of the Rich Life Study team. I'm also a project manager on the study, and I'm on faculty in the School of Public Health. So I am really excited to be here. As you can see from this bio, I've actually worked in collaborative care types of interventions for a long time. When I graduated from college, I worked at a hospital. It was the hospital I was born at. But I worked at a hospital that implemented a community health worker program, and this was like in 2003. So I've spent several years thinking a lot about community health workers and how they interact with the health systems they're in. So I'm very excited to see you all face to face. This is kind of a long time coming because we've been thinking about the training for a while. We've been wondering who exactly the care managers and CHWs would end up being, and it's all of you lovely people. So this is really exciting. So welcome, thank you all for coming. As Dr. Cooper mentioned before, it's a rainy day. Traffic was bad for almost everyone. I don't know why I'm laughing because that's not funny, but traffic was bad for people, so I appreciate you guys taking the time to be here. So what we're going to do in our presentation today is to kind of circle back a little bit with what Dr. Cooper mentioned regarding the core roles of what community health workers and care managers will be doing. And the interesting thing is, you know, we're talking to you all as seasoned community health workers and care managers. So we know that you have a lot to teach us and a lot of skills that you will bring to bear in your role with the Rich Life Project. But we're going to talk about these roles, and then we'll also talk about some health promotion and disease prevention concepts, which Carmen mentioned earlier. And then finally, we'll talk about how these different sides of the care team interact with one another to support patient health. So first, we're going to start off with community health workers. And I really love you all, but community health workers are like my heart and soul, so this is like my baby. Sonia is nodding because she knows this. So I worked with the JCHIP program before I became involved with the center here, the Center to Eliminate Cardiovascular Disparities. And I was one of the people who had the privilege of helping to shape the community health worker intervention. So let me ask you guys some questions. For those of you who are community health workers, how would you describe your role and what you do for patients?
I think we're Jacqueline of all trades, or Jack of all trades. We get requests from case managers, from the members, from families. It could start out just outreach in regards to somebody may need transportation assistance. And then before you know it, it's like, well, no, I really need somebody to come in and help care for my mom. Could you provide resources for that? We're low income, we can't afford fee-for-service. Can you tell me if there's any county services that are available? I can't get hold of my PCP and I'm having chest pains. Can you tell me what to do? It's like, yes, you want to call 911. You know, so I think we interact a lot with the member and the member's family, more so than some of the other people on the team. You know, sometimes when a member goes to see a doctor, it's once every quarter, and then we'll be talking to them every month or every 2 weeks just to see how they're doing in regards to updating their care plan and making sure that they're getting the service they provided, or at least point them in the direction. You know, I lost my Priority Partners card. How am I going to get another one? Oh my God, I don't have my state ID. I lost my driver's license. I have a court date coming up. So we just get a lot of different questions from all over, and that's what makes the position so interesting.
That's why I like it so much. Great, thank you, Mary. Are there any other thoughts from any of the other community health workers?
Oh, please add on to it.
Summed it up pretty well. I believe like the most important tools in being a community health worker is your eyes and your ears, and that we build that bridge between the providers and the patients, because a lot of times when they do go to the doctors and the providers, they only see them for 15 minutes to half an hour on an annually visit out of 12 months, and when we go to a patient and assess the patient and what their barriers are, what their needs are, you find a lot of other things going on in the background that they don't have a chance to discuss with the providers, and the reason why their attention is not focused on their health or taking care of themselves. Every patient and every situation is different. With me, I always try to meet my patients exactly where they are, and building that relationship and that rapport with them is just so important. And they don't call you, and they'll start following you. But your eyes and ears is so important to listen and to be observant. And then once you're able to assess and find out, you know, where their struggles are, then you can break down each one at a time and find out how you can interact and help overcome or meet those goals for patients. So, Vanessa.
Any other thoughts? And then I'm going to go to the next question. Yes.
That a lot of times we're like a cheerleader. I find myself with a lot of the patients that I follow. A lot of times there's a lot of fear with a new diagnosis, or when a condition worsens, or even a fear of going to a new specialist. With a lot of the referrals, when they do have a lot of complicated health conditions, we're there where the doctor just hands them a slip of paper or says, okay, I'll see you in 3 months. A lot of times there's a lot of deep-seated fear based on family histories, or just a lot of misinformation, that we're bridging that gap with cheerleading them into, well, this isn't going to be that bad, you know, or I'm going to be there with you, or I'm going to make sure you can get there and get home, and I'm going to help you to, a lot of times when there's a patient that is has a literacy barrier, we have to be there to interpret what it is that the doctor says with a big long word. We have to do our homework to be able to say, to break that word down, or to give them an understanding in layman's terms what that means concerning their health.
That's great. So let me ask one last question to the CHWs before I advance to the next slide. What's the most challenging aspect of being a community health worker, and what is the most rewarding aspect of being a community health worker? Lauren, I'm going to choose you.
I would have to say the most challenging is that you never know what you're going to get for the day. You can be calling someone for something completely different from what they bring up. So now you're on a whole different topic. So sometimes barriers may get delayed, or barriers that you think that you may have, or that they bring up more to the table, I would say. So sometimes it's like a puzzle piece trying to do A, B, and C before, you know, X gets done. So I would say that's definitely a challenge. I would say the most rewarding is just the simplest things that you can do for someone, and the appreciation and the gratefulness that you receive back and feedback. I think that's the best.
That's great, thank you. Anyone else? Vanessa?
With some of our patients, I find that the most challenging things are actually is the mindset of our patients. You can educate them, and they can, like if you have a patient that have a history or family history of diabetes, and they've watched their parents actually die from the disease itself, and because it was unmanaged, and then you show them that, well, you can take other options, you give them these other options, and you work with them through it, and because of their mindset, they think, some of them said to me, like, well, we all gotta die from something. But it's just like trying to get them out of that mindset, like, but you know, it's options out there for you, and you can do this, and you can do this different from the way your parents did it, or the way you've seen other family members do it, and make your chances, you know, increase your chances. So the mindset, but the rewarding part of it is that being able to be a part when they do meet those goals, and they do have those successful outcomes. I feel rewarded. First of all, I learn from them. I learn from my patients a lot. And sometimes things I don't learn until I'm actually on the case, but it's just some extra tools for me to be able to access and be able to be resourceful to other patients as well when I encounter those. But also the reward of being a part of putting somebody's life back together. That's a reward for me. I'm blessed in that.
Thank you. Thank you guys very much. And don't worry, care managers, you'll have an opportunity to answer these questions too. We're not leaving you out. But thank you all for speaking so eloquently about the roles that you fulfill in the patient's lives, the challenges that you encounter, the rewarding aspects of your job. And so really when we think about community health workers and the core functions they serve, it is completely similar to everything that you just said. So helping patients to navigate and access community resources. So Mary, as an example, mentioned things that happen to a patient who loses their state ID, and the role that you would play in helping that patient get that information back. You all talked about very similar types of things. So the things that we know that community health workers do have a lot to do with that type of linkage, whether it's linking them to other members of a care team, linking them to community resources that they need that address what we typically call social determinants of health. So utilities, transportation, all these different barriers that affect the extent to which patients can take care of themselves. But then there are specific ways that you guys also help support behavior change. So the things that Vanessa talked about in terms of the patient outreach. So what you were saying about changing the way that a patient conceptualizes their health care. That they go from thinking, well, it's inevitable that I'll die of diabetes, or it's inevitable, we're all going to die anyway, so what's the point? To, well, actually, I have some agency in this matter. I don't have to actually die in that way. I mean, yes, we'll all pass, but it doesn't have to be quite like that. Engaging with patients and their friends and family members. And so I remember someone had asked about that earlier, and I'm sorry I don't remember who it was. But someone had asked about, okay, so it was Mary, but you had asked about, you know, what happens when a patient has different family members or friends that want to be involved in their care, and how are we capturing that in the Rich Life Project? So we do have that as a question on all of our assessments, but again, even though the patient is kind of the primary person that you're interacting with, you do have to account for all of the other people that are involved, all the other players that patient engages in the context of their care. So that's what community health workers typically do. Educating patients about health conditions, that's kind of like an essential part of what a CHW does, and something that we know that you'll bring to the table when it comes to the Rich Life Project, and all of these other things. So counseling patients and acting as a form of social support for patients and just another ear. I really liked what you said about how community health workers, that the most important aspect of them is that they're eyes and ears. And so, you know, really listening to what patients have to say, advocating for patients, you know, all of the things that you mentioned dovetail very neatly with what is said. I actually don't even have to go any further because you all already mentioned this. But I think it's interesting to be able to see how the things that you're doing are reflected in what we know in terms of the evidence about community health workers and their effectiveness and the roles that they fulfill. So it's great to see that there's that level of convergence between what people do, like on my end when I do the research side of it, and on your end as the frontline people who are really interacting with patients. And now, it's the care manager's turn. So now I'm going to ask the care managers the same question. And bearing in mind, I know I said what I said about CHWs, but I really do love care managers too. I think you guys are awesome. When we worked in the J-CHIP program, the care managers were the heart and soul of the entire project. So I have the utmost respect for what you all do. So with that in mind, how would you describe your role and what you do for patients?
I'm a care manager in Western Maryland, and I'm embedded, so I see patients in our office as well as I do home visits to see their home situation sometimes. A big part of what I do is help them coordinate what their providers are ordering for them and help make sure that they keep on track and try to encourage them to look at the benefits of keeping on track with their appointments and their medications and things like that. I don't use the community health workers as much. We've not until recently even had one for our region, so not been real involved with them. I'm looking forward to working more with them.
Oh, great.
Yeah.
Thank you. Teresa. I'm trying to make sure I get everyone's names. I'm not trying to call on you, I'm trying to remember your name. Danielle?
Yes, I see care management as an opportunity to give the patient a alternative assessment that corresponds to the medical assessment, but this time we're going to assess for the barriers to accessing care. And then from that, we're going to find out what are the patient's social needs. We're going to find out what the patient's level of adherence is to medications and how well they do it. We're going to find out what's happening with the patient socially, like what's their home environment like, what community are they coming from. And then you factor all of that and then you put together a plan of care which will involve patient teaching, patient education. Then you would also involve the community health workers as a second leg to sort of help maybe focus in on some of the focus areas that you found in your assessment of the patient, which could be housing, which could be food, which could be, oh my God, I don't know how I'm going to pay for my medication this month. So that's what I look at care management like.
Yeah.
That's how I look at care management.
I really appreciate what you and Teresa just said, because I think one of the things that comes to mind in listening to both of you is how you really take into account where the patient is coming from in developing and then implementing a care plan. Any other thoughts about, yes, Cheryl?
There's many things, you know, case managers, and they said it very well, but I guess one thing that stands out to me, because recently it's been a hot thing, is I feel that I am the interpreter for the patient. I don't know how many patients are told instructions and either they have no clue really what is being said to them, or they see it and they just ignore it because they know that, yeah, right, there's no way that that's something in their life they'll be able to do. So you kind of take what they're being told from all the specialists and so forth and sit with them and make it applicable to what they can accomplish.
That's great, thank you.
Yeah, I had one more to that.
Yes, you
After-
can, and then I'll,
Yeah.
thank you, Sonia.
From what she was saying, that just brought to mind patient advocacy. That is so big with the work that we do, advocating on behalf of the patients to make sure that they get what they need. Because a lot of times patients just are not that fortunate with being able to speak up for themselves when they come to the providers and they have their visits. They miss a lot of stuff that's important to them that they should talk about with the provider. So definitely being a patient advocate is very important too.
Thank you. Sonia?
One suggestion, nurse care managers should just be care managers, because we do have a lot of social workers who
Yeah.
are care managers, and it just should be care manager.
Yeah.
Just a suggestion for the future.
Yeah, thank you for saying that. And for this project, we really wanted the care managers to have a clinical background, so that's why we kind of excluded it to those with a nursing background. But we totally agree. We actually did talk about this a few times too. But yeah, you're absolutely right.
There are certain things that we are asking the care managers to do that were not in the scope of practice for social workers. So. But we, so I don't know whether we are actually going to have to make some changes to our protocol based on who we have available to us. Because again, like I said, this is like a practical trial, a pragmatic trial. So are all the care managers that are here nurses?
Yes.
Okay.
Okay. But thank you, Sonia. That's a point well taken.
As we adding staff, we
Yeah.
may want to add a social work case manager to really tackle the psych aspect.
Yeah.
Since we don't have the health behavior specialist, so we may want to just start looking at that.
Yeah, thank you. So I'm going to just talk very briefly about the core functions of a care manager. And again, synergy between what you said and what is listed on this slide. So coordinating care for chronic disease management. One thing I do really want to highlight is that in the context of the Rich Life Project, the care managers are kind of the quarterback of the team. Now, I'm saying quarterback as if I know anything about football. I really don't. All I know is that quarterbacks call the shots. And so in a similar fashion, the care manager will work really closely with the primary care provider, but the care manager is the one, because of the breadth of training you have, as well as your awareness of all of the different clinical aspects that a patient needs in terms of support and their social aspects. The care manager is the one that's kind of going to help dictate the direction of the care plan and all of the support a patient receives. I think that is pretty consistent with the model that you practice at your respective clinics or practices and health systems, but I really wanted to underscore that point. The other thing is, as you all stated, care managers provide patient-centered care. The goal is to provide patient-centered care. And so when we talk about what Teresa and Danielle said regarding assessing the home environment, going in and really seeing what the context of which are the lives that patients are living, that's where that patient-centered care comes into play, where you're really accounting for the specific needs that the patient has and the ways that you can address them to the extent that it's possible. And then what I mentioned earlier about the quarterback part. So we would be collaborating with different members of the care team. And as Dr. Cooper mentioned in the broader overview of the study, some of the practices have multiple members of care teams. Some, it's just going to be the care manager and the community health worker. And it sounds like what you said, from what you said, Teresa, that sometimes it's actually just the care manager, depending on the practice and what resources they have available. But regardless of the size of the practice, the hope and the expectation is that the care manager is going to engage with all of the different members of the care team when you think about delivering care for that patient. So that includes identifying risks, identifying the things that affect their health, that going through that assessment. Our assessment is really similar to the ones that Johns Hopkins Healthcare uses. So when you see it, it's going to be pretty familiar to you. Performing medication reconciliation, which I think is what Danielle spoke to earlier, and then patient education and counseling for health promotion. So that even though it was Mary who brought it up, it still holds true for both community health workers and care managers, that you'll be giving them patient education materials and kind of walking them through it. And there is a session that we have as a part of this training that's devoted to that, and we'll go into it in greater detail. And then finally, the central role of the care manager in some ways, developing care plans and having those care plans really be contextually based so that the care plan encompasses all the different needs that a patient has. And so now we're just going to go through some health promotion concepts, and here is Carmen.
Awesome, great. Health promotion, is there anything in particular that comes to mind?
One is like a definition to me, which is sort of helping the patient to achieve an optimum level of wellness for wherever that patient is. Whatever the patient's level of optimum wellness could mean.
Anything else? Yes, ma'am.
I think of preventative health, making sure that the patient has their screenings for mammograms, caps, or whatever on a regular basis, flu shots or whatever. So look at prevention and screening.
All right, anything else? There's no right or wrong here, but just what your perception is or what comes to mind. So here we have two, what I think are fairly different definitions of health promotion. If we could take a quick look reading them and then just share your thoughts on which one jives with you more. Okay. So we've heard a lot from this side. Anyone here? Okay, yes, ma'am.
I
Suzanne.
think the aspect of empowering people is sort of meeting them at where they are and empowering them to do versus enabling might be breaking down the barriers that are there, which I can see why that's the World Health's objective. But empowering is actually getting down to the nitty-gritty with individuals on their individual basis.
Okay, so you like Pender's
Yeah.
definition better? Okay. And Vanessa?
Well, I would say this too, because of empowerment, one thing is the patients will be able to live with us forever. And they need some sense of education and resource that will help them take the initiative to want to help themselves, because we're not going to be there forever, honestly. So I want to see them on the street later better. Stop and say, oh, they're still doing good. Excellent. Can help other people.
I think that the Pender definition is all encompassing. So it says that it's the activity directed toward empowerment. So that means all of the things that we do on the basic level to help folks to sort of figure out what their needs are and then empower themselves through being able to maybe advocate on their own behalf or understanding what the diagnosis means to them and why it's important to take blood pressure medication, and then empowering people through goal-directed behavior. So that's like teaching folks how to set a goal for themselves and showing folks what's realistic. And that could be, I take my blood pressure medication for 1 week straight, and that's cool. Competent self-care, that just means that we have empowered people enough so that now they can be good managers of their own care, and that's what we should be promoting for patients. Is one thing for us to be like assuming the care of our patients, but it's another thing that's really great is that we promote self-promotion of care so that patients can be able to care for themselves ultimately.
I like the whole definition of this, but I feel like in the beginning, essentially they're saying the same, you know, the process of enabling people to increase control, that's empowering them. So I feel like, you know, the wording is just different, but enabling people to increase control, that's empowering them to, you know, to be more involved. But I like the whole definition, just sounds simpler to me. And also, I feel like I'm just thinking in a global way. I would feel the whole definition applies more to populations outside of urban settings or what you call developed nations or whatever, you know. But yeah, that's how I feel. I like the WHO definition better. Okay. I actually liked the WHO definition better because I'm thinking about, I thought it was a bit more, it in some ways included what Pender included. And I like the idea that they highlight that this is a process and that this isn't something that's going to, you know, be solved with just the goal-directed behavior. Or maybe the person doesn't need the goal-directed behavior. To your point, we have to meet the patient wherever they are. So getting to the challenges that you had mentioned in terms of, you know, people's mindset, right? Encouraging them, building their self-efficacy or their level of self-confidence so that they can feel more empowered to take on the behaviors or the lifestyle changes that they need to improve their health outcomes, right? So Albert Bandura is credited with developing the theory to explain self-efficacy or part of how self-efficacy works. So this isn't the entire theory, but he suggests that there are 4 main experiences that will impact one's self-confidence about a particular behavior. So their past experiences, so what may have happened with them, or what their experiences may have been when trying to implement or practice their behavior. Vicarious experiences, so seeing other people in a similar situation, either being successful or unsuccessful with practicing the behavior. Verbal persuasion, so what we as healthcare workers are telling them or somebody else in their inner circle. And then how they feel, so their physiological feedback, how they may feel when practicing the different behaviors. So maybe we can talk through this using an actual example. So let's say we have a young woman, maybe not that young. Well, yeah, she is young because she'll be 50. So Rachel is 50 years old. She's got her 2 kids. She has uncontrolled diabetes and hypertension, has a full-time job. So what may be affecting her self-efficacy for managing her hypertension and blood sugar? Her time. So that would fall into which category? That's a valid one.
Vicarious experience.
Time, we'll put that one in a parking lot, the time one. But what else? Is there a marker? I'll go to the other side.
Oh, there is one, I'll see it.
There's one over here.
What she believes that, like, how high up on her list of things to do is caring for the diabetes and high blood pressure. So what she,
In relation,
how does she feel that the diabetes and high blood pressure may or may not affect her health in any way?
okay.
Does that make
So
sense?
maybe her attitude about
Yes.
her condition?
Yes.
Okay. Anything else?
Her perception of what those conditions are. You know, people think diabetes is, you know, how many times do we hear, I have the sugar?
Yeah.
So now,
Sometimes we want to have the sugar. You know, they don't understand what their perception of the whole disease process.
okay. So a mix of the two, so lack of understand, so lack of, that almost sounds like a lack of knowledge, understanding, okay.
I was going to say the fact that maybe the physical manifestations of the disease, she hasn't felt them yet, you know, hasn't lost her eyesight from diabetes, no, nothing, no symptoms, you know, so maybe she just feels maybe I'm not that sick. Or I guess in that physiological feedback.
none of the markers work. Okay, so we said lack of knowledge, perception. She's not feeling anything yet. It doesn't hurt. Anything else? No.
She knows people who have the same conditions and, she hasn't seen anything happen to them. Like, oh, my cousin has the sugar or whatever, and they're fine. Oh, my dad is 80 and he has high blood pressure and he's still here.
It could be, I'm sorry, it could be that she doesn't like how the medication makes her feel, maybe, because she is so busy, she has to work. So it could be that whenever she took the medication, it made her feel more sick and made her unable to perform her day-to-day activities like go to work and make money to make a living.
Okay, good. Any feelings or thoughts about this particular framework for thinking about self-efficacy? Do you like it, not like it?
I think in a sense of bringing this to somebody's attention, like when you see them face to face and maybe using it as a tool to find out where they fall on that spectrum, to then try and implement some kind of intervention around wherever they fall on the spectrum of efficacy judgment, so that you can help the patient to improve their health outcomes.
Okay, that's a good thought. I hadn't thought of that. using it in that way.
We know that if they are tied to these things, if that's what we're saying, are the determinants that then gives us places to probe to see what could be the barrier that they're not even aware of as a way, for instance, the sensations of how you perceive the emotional influences, once they start thinking positively about something, small increments can change their, slowly start building a connection.
Great, so yes, all of these, and then a number of you brought up some issues that don't quite fit into this, right? So to some degree, one may argue that it is a little limiting or not broad or all-encompassing enough. So here's one by Nola Pender, the one that wrote the definition that most of you liked. She's also a nurse scientist. And so she came up with this model to explain the process that people go through when it comes to practicing health behaviors. And so her argument is that the biggest determinant for someone practicing a behavior is their commitment to a plan of action, or their intention to actually practicing that behavior. She does acknowledge that, competing demands can play a role, but the main determinant is their commitment to that plan of action. And then that commitment is affected by a whole series of other factors. So their perceived benefits of the action, some of you brought that up already, their perceived barriers to action, their levels of self-efficacy, their attitude about the behavior, interpersonal influences, so us as healthcare workers would fall into that category, their situational influences, and then these in turn are influenced by prior related behavior and then personal factors. So any thoughts about this model?
I like this one. I think this one's a little more realistic.
More realistic because it encompasses more?
And I think it's also more realistic because when we're working with the patients out in the clinics, community and whatnot, the one thing is, assessing for readiness. If a patient is not ready for whatever intervention, you're just not getting anywhere, So I like this commitment to a plan of action. It means, they're ready to follow through.
So what are some of the things that you end up talking about to assess their readiness? What does that look like?
It's like a lot. There's a lot of bits and pieces to it, It depends on what the patient's perceived goal is sometimes different from yours, so you have to look at what it is that they want to achieve. For instance, if they were referred to me for, I don't know, hypertension or diabetes, if that is not their primary concern, I know from my end, I already know so the primary care physician sends them to me for diabetes or hypertension management. That is not the patient's primary concern. They're more worried about my transportation and other social determinants of health, which directly or indirectly impact, their diabetes and hypertension, stress, access to food resources, or like all those other things, So my assessment for readiness to deal directly with the hypertension, I know they're not ready yet until we can take care of these other social determinants of health, transportation and food resources and whatnot. So it's just kind of knowing, by asking the patient. I just ask the patient. That's always.
So assessing some of their perceived barriers to the action. Yes,
And
ma'am.
I want to say that's why the case management assessment is so vital, because it addresses the social, transportation, what other things that might come to play. And if you don't do the assessment, you might miss an important barrier or an important concern. So just following that, because sometimes a patient might not blankly say, well, I just don't know what they're talking about. They may not say that, but if you go through the assessment process, and it gives you a form of finding out information as well as sharing information, by the time you do that, you pretty well know where that patient is, and you can meet them at that level. But that's why the tool is there for us, the assessment tool.
Well, being in the community where I am, it's kind of easier for me than some of the case managers, and it's not a requirement to see patients in their homes, but that is really, really helpful for me. A lot of times I'll try to do the assessment in their home, because there's things that you see and things that you hear that you would never have known if I had been sitting in my office doing the assessment with them.
Can you share more about that? Like, what are the types of things that you see and hear that become so critical to their care?
Well, I went to see somebody just recently, and it was a patient that had a CVA, and she was on the phone or in the doctor's office. I think she's really good at covering up her memory issues. She's living with a spouse with memory issues. I probably would have never even realized the spouse's deficits had I not went to the home. And I'm not sure I would have picked up on all of, once I went to the home and we started talking about things, and I said, well, show me your list of medicines. And she, I had a piece of paper that was from 2013. Show me, it was just this whole broad, and I had a new case manager with me, and it was funny when we left there, she said to me, wow. I said, yeah, I don't think I'd have picked up on half of that stuff had I not been here. Because she was really good at covering up in the doctor's office. She knew the right answers. She was a retired nurse. She knew the right answers. But when I saw her in her own home, in her own environment, it was different.
Any other comments about this model?
No, but I have a comment in regards to what Teresa just shared. I think it's wonderful that as a case manager you're going to the home, because we as community health workers, we can go out to the home and we'll see things on, the social side in regards to resources, and it's like, oh, well, maybe, these steps, you're going down these steps, but there's no light. We need to make sure that you have plenty of light because of your low vision. But then from the medical side of things too, they're able to catch up on things that we're not trained to catch on, because we're not on the medical clinical side, we're on the social side of things. So I think it's wonderful, and I commend you for doing it, so thank you.
I thought I saw a hand. No, you didn't. So one, I guess, other limitation of this one, again, is that it doesn't bring into, one, it assumes, I would argue, that a lot of the patient's behavior is in their control, and doesn't necessarily account for all the barriers that a number of you just mentioned. For instance, their access to transportation. But did you have a comment about that?
Their
No.
behavior is in their control?
Yeah.
I would say that's correct.
Okay.
Sometimes you'll get somebody who, they just want to act up, or
Yeah, they act completely different in the house.
then you see them
Compared
in
to
the
the
doctor's office or
Mhm.
over the phone, and, you know, they're in their home surroundings, they feel comfortable, so they'll express themselves in a way that you would never have imagined.